Moving on to examine the cervical spine, we palpate along the level of the cervical spine, including palpating at the level of the occiput. We then get the patient to move with active movement, including flexion, extension, lateral flexion and rotation of the cervical spine. It's important to instruct the patient as how they are to do these movements so that they don't lift the shoulder when they attempt to do lateral flexion of the cervical spine. We then palpate down the thoracic spine, palpating along all the level of the spines. Percussion tenderness indicates a deep abnormality, either infection or tumour. Thoracic spine movements are always examined with the pelvis fixed, such as with the patient seated, examining particularly for rotation of the thoracic spine. There is limited flexion and extension in the thoracic spine. We palpate around the sternoclavicular joints, around the costochondral joints as they insert into the sternum, and also palpate around the ribs by squeezing across the rib cage both laterally and anterior-posteriorly. Finally, we examine the lumbar spine. This is indicating a Schober's test, which is a measurement done 10 centimeters above and 5 centimeters below the posterior superior iliac spines. This is a measure of distraction of the lumbar spine, and in conditions such as ankylosing spondylitis, this measurement is virtually zero. If there is movement there, the line will extend from 15 to 20 centimeters. We then examine lateral flexion of the lumbar spine, again making sure that the patient moves his hand directly down the leg rather than flexing forward. We test for extension of the lumbar spine, and this completes the examination.